everyone. Welcome back from lunch. I think people are still mingling in the back, but hopefully will trickle in for the next session, which we've got 6 more presentations from teams. It will be the same format as before, so 10 minutes each, with some time for questions after. And I don't know where our first presenters are, but the first presentation will be Human-in-the-Loop Evaluation of Assisted Depression Screening with Lekhansh Shukla and Diptadhi Mukherjee. Thank you.
Hi, thank you. Good afternoon, everyone. I have the unenviable post-lunch session. So, yeah. Could we have the slides, please? Okay. Oh. Okay. I'll talk of the team later, but then I intend to build a story first. I don't think I need to be telling here why we must be studying depression. It's one of the most common psychiatric illnesses, and of course is one of the 3 illnesses which are allowed by the call to be studied. But then more importantly, it is also one of the most undiagnosed conditions. So that is the motivation for studying depression. Now, what is the motivation? Why do we need diagnosis and measurement support for depression? And the way we see it, the 2 main reasons are task sharing and diagnostic overshadowing. Task sharing is a WHO idea, if you will, that in countries where there are not enough psychiatrists, diagnosis and treatment of depression and other mental health conditions can be done by non-psychiatrists. And even for measurement research, for example, prevalence studies, for example, the National Mental Health Survey that our country has had, India has had, or which the Sri Lanka is having right now. Basically, it's been done by laypersons who have had a day or 2 of training on a particular instrument, in this case being FLY-11, that is the Flexible Light Interview for ICD-11. There's also literature on diagnostic overshadowing, that when there is a substance use comorbidity or a physical illness, it is likely that it would overshadow pre-existing depression. And what we see is that people who, for various kind of disadvantages, and that depends on which part of the world we are talking of. In certain parts, being poor or poorer is the biggest disadvantage, which increases the risk of somebody having depression, are also the risk factors for never getting diagnosed with depression. So that kind of is a double jeopardy, and that's our motivation why we think that this is an area where diagnostic and measurement support would be a good place for the AI to augment the abilities. Now, what should be the contours? And we kind of drew it from first principles. Of course, we have some research on this. But then what should be the contours of AI's role in the diagnostic process, somebody getting a psychiatric diagnosis? And to our mind and to existing ethical standards in research, number 1 is cautious. And why I say that is, of course, AI can be deterministic, but since we are talking of generative AI, to our understanding, these are, by their very definition, at least LLMs, are non-deterministic systems. They are stochastic systems. They can give different outputs to the same input, although one can, of course, regularize it to a large extent. In case of giving a diagnosis, the cost of a missed case or a false positive, both are equally high. In one case, there is no diagnosis, therefore no treatment. In the second, there's stigma, perhaps a lot of worry on the part of the person who has received this diagnosis. And we will definitely have to make it, because we will have to make it understandable. We will have to use language to make it understandable. So there must be some semantic interpretability, because if you look at it, doctor and patients use language to communicate. And therefore, a lot of existing research, which has just looked at latent signals in, prosody, etc., might be very difficult to communicate to the patient. We also believe that it must not be limited by linguistic divides. It must ideally not be behind paywalls. And it must be scalable and affordable. So even if some governments eventually try to deploy this, the last person in the queue must be able to get the benefits. And for that purpose, we believe it must not be a wrapper depending on closed source solutions, because on closed source solutions, one does not know what the pricing would be someday down the line. And this is a theme that we have been discussing for quite some time. I mean, to a large extent, the ground truth is established. We agree that DSM-5 and ICD-11 are the diagnostic systems for diagnosing depression, and we have to do that for empirical research. So there's some amount of reductionism already inbuilt in using those systems. But then beyond that, of course, culture and language are non-trivial factors when evaluating psychiatric illnesses. And I know a lot of you cannot read the Hindi script, the Devanagari script. What it says is, man uchat hai, the best translation by what I would do, I'm a bilingual domain expert, if you will. I'm a psychiatrist. Hindi is my first language. English is an acquired language. The best translation of this is, my mind feels barren. Google Translate, which actually performs much better than the other open source, it's not open source, I'm sorry, the other affordable solutions, if you will, gives mind is upset. Now, I need not tell you how much depth of, expression is lost between mind feels barren and mind is upset. And when we talk of the GPT model, which is the only model from the group, which is open source actually, it somehow says mind is high. Now imagine if this kind of mistake happens on the interview transcripts, then what kind of diagnostic accuracy are we talking of? Transcription is an equally problematic thing, including models which, one of the models is Indic Whisper. It's the Whisper model which has been fine-tuned on Indian languages and is supposed to have state-of-the-art performance for transcription. Bahut anxiety ho gaya tha, the English translation is, I was feeling very anxious. Now this is code mixing. We like, in India, most of the people speak at least 3 languages and they tend to switch between it very frequently. And transcription systems struggle with it. So how does one build such a model? I only have 5 minutes left, so I'm going to hurry this one up. But just the basics. We consulted with grassroots level mental health professionals, non-psychiatrists. So these are organizations like the Institute of Public Health and another non-profit organization, culture and linguistic experts. And we formed a lived experience advisory panel. The consultation tracks were around these themes, and I'm going to come back to them because one of the things that we were discussing was, should we be translating? Should all languages be translated to English before we actually, do inference on them? And we got quite an interesting input from our lived experience experts. So we first of all posed a question to them: should we have a camera? Because probably getting video and facial expressions might increase the accuracy of the model. But they felt that it's going to be too intrusive and it's never going to fly. Nobody would like their psychiatric discussions to be video recorded. We discussed with them, what is your, why not try and build a model from scratch? And they felt for right now, with the limited resources we have, probably getting a faithful translation is a better idea. They also highlighted that one of the things that's most important is the model should communicate its uncertainty to whoever is the doctor who is using it. Because they would want the doctor or the mental health professional, because they would like that doctor to know that this model is not certain on this particular prediction. We also form language evaluation groups, and that's to be taken on forward. So I'm not going to go into the details of that, but the idea, the plan is that an interview is happening between a clinician and a doctor, and it's happening in 4 Indic languages. Now let me just draw your attention to how many people speak this. So Assamese is perhaps the most or the least spoken in that list. And we have about, Diptadhi, correct me if I'm wrong, about 30 million people who speak that language. Hindi is the 3rd most frequently spoken language in this country, in this world, I'm so sorry. And Bengali is the 7th most spoken language in this world. So what we are talking of is a system that can listen to this conversation, can do a good transcription, not only a transcription with paralinguistic annotation, that is all the emotions being preserved, can translate it to English, keeping in mind the cultural idioms of distress, And then we finally have an inference engine that can feed back to the person who is conducting this interview, which might be a clinician or a mental health professional, can feed back what are the probabilities of this person having depression with an explanation. Okay, one of our deliverables is reusable data set. We don't believe data is the new oil and AI is the industrial revolution. We believe it must be something more renewable. So we will be generating a lot of data you can see on the slide. One of the most interesting would be psychiatry clinical reasoning. This is a data that does not exist at this point of time. How do we de-risk it? By conducting a pilot study, which is what we are doing. And we are finding that the word error rates for Hindi and Kannada, which are the two languages we have included in pilot, is above 85%. Translation tends to flatten most of the emotion, and so that's something we will have to build ground up. And clinical reasoning can be caught by a modified thought aloud protocol, but one also has to have a probe in it because the clinicians tend to do it more automatically. So thank you, all of you. The three institutes on this are LGBR IMH Tezpur, and this is some trivia for people who belong to UK or London. There is a very interesting relationship between tea and that particular place. And somebody back there was asking me, Mr. Mistry was asking me, how old is Nimhans? So I was asking him, tell me what is old enough. It was established in 1847. Some of you would have been to Maudsley Hospital, I believe. So that's a trivia for you. The architecture is an exact copy. So if you're visiting Bangalore, sometime come there and compare the gardens. Thank you.
Hello, Vipul Prasad, General Practitioner, Clinical Associate Professor in Primary Care and Adult Mood Disorders from the University of Nottingham. Thank you. Your speech is so very inspiring. My ancestry is from Nalanda in Bihar, where there is a university from 6 BC, so a little bit older than 1847. And some of my relatives, they are female, then many of them are aging now. They did not go to school and they speak Mukherjee. And their language and ways of expressing their emotions will be somewhat different from your Hindi-speaking clinic population. In any work that we do, I'm a population health scientist by background, we are always going to leave some of our patients behind for now. So please tell me how you're going to ensure that my aunties who didn't go to school, who speak Mukherjee, which is a very rare dialect and is not written down, can be included in your work in the future.
Thank you for your question. Let me put it this way. The people in the country called India right now we have 26 scheduled languages. So that's more than the 22 that the whole EU has. And somebody can correct me, some European can correct me. I believe EU has 22 scheduled languages. With the limited resources at my hand, I have no option but to exclude certain languages, including Maithili, which is a very poor resource language at present. If we have more philanthropic grants like the one that we are talking about right now, there is a chance that your auntie might have a model that can speak to her because she's not a big enough consumer group. I'm so sorry to say that. And so, yes, through the next philanthropic grant, I would like to cover all the languages of India.
Thank you.
Thanks.
And it's Mukherjee, which is even rarer than Maithili.
Okay.
Could you elaborate a little on your chain of thought reasoning data sets there? I think that's a very exciting space, and so I'd love to hear more.
Thank you. Yes, so that's a part of our pilot work that we have done on about 15 transcripts right now. And what we did was we make another psychiatrist listen to the recording. And at the first time, we didn't give them any instructions. We just observed them. What are they doing before they come to a diagnosis? Then we formalized this process, asking them to think aloud. And then we realized that there is some amount of reactance that comes in. And because clinical reasoning is very intuitive, I'm sure all clinicians would understand, we don't reason in discrete tokens. We actually reason in a latent space. This feels like depression, right? So to actually make the clinician say it in words, because words are all we have to communicate between two human beings, not the latent space, we have to actually have another agent that can provoke this emitter. So I am the emitter. I want an agent who provokes me, who prods me repeatedly, but then the patient said that too. And then I respond to it. And then I feed this whole thing into an LLM and get a formatted chain of thought, which becomes my goal trajectory for probably training the model that can automate all of it.
Seeing as you mentioned latent spaces, I was interested in why you want to bring the input to the LLM down to text, and specifically English, with annotations, rather than use the multimodal mode of LLM reasoning to sort of shortcut that process and go directly from speech to some sort of, I'm presuming that there's a good answer, but I was just interested what that might be.
Thank you. So both questions are linked if you look at it. I don't want to dampen the techno optimism that we are riding on right now, but the fact remains, most LLMs cannot understand spoken Hindi and Kannada. For such systems, I would not like to, move even one abstraction layer above and ask them to understand the prosody of Hindi and Kannada. I think it's a kind of an epistemic injustice. When they can't understand the words, how can I actually trust them to understand latent signals like prosody, etc.? As I said, the compromise to translate everything in English, and we are completely cognizant that this will lead to some loss of fidelity, and this will lead to some loss of cultural idioms of distress, etc. All the foundation models which we would be using, we cannot build a model even with a large grant that this is. We can't build a reasoning model from ground up, and somebody can correct me if I'm wrong on that. We will have to use one of the open source language models. So we cannot correct the historical injustice that most of these models are very good at English. In fact, we may as well use them at their strength and just train a module that is a faithful translator, is the thought process behind this. Thank you.
Thank you. So I'm going to keep it moving because we've got a lot to cover in this session. So next is GenAI Therapy Assistant for Post-Traumatic Stress Disorder with Jacqui Gratton Kolbassia Haoussou.
Thank you. Hi, good afternoon, everyone. Thank you. Jacqui and myself, we are from Freedom from Torture. It'll be late, I'm going to give you a little bit what that organization is. But, you want to start? Yeah.
Okay. So, I'm Jacqui Gratton, I'm a consultant clinical psychologist and associate director at Freedom from Torture. Thank you. So, oversee the clinical services there.
And I'm Kolbassia Haoussou. I'm the director of leadership and influencing and looking at anything lived experience and also co-designing and co-facilitating and co-production at Freedom from Torture.
In the spirit of wanting this to be interactive for the people at home as well as for you in the room, it took me a long time to work out QR codes, but since I have, I'd like you all to be able to use it. If you've got any, so some of you might have time at the end to answer questions, but if you've just got thoughts or questions, things that you liked, that impresses you, risks that you spot, any solutions along the way, then please do let us know. Thank you.
All right. I think, as you know, many in this room, we are also going to exploring how we can use the benefit of, AI in order, to reach more, in order kind of to use to address, the issue of, mental health. I mean, from our organization, Freedom from Torture, and, the group of clients that we see are torture survivors. And in a period of a year, we see around, 350, survivors from around 41, country of origin, and age between, 15, to over, 16. So the general problem that we try to address is the global majority excluded from mental health innovation and also AI, data set, and that, lead to high, risk of stereotyping and also, biases. At Freedom from Torture, co-designing is not is one of our key selling, point. We've been doing that for, over 15 years now. I went through Freedom from Torture as a client, and then after that, after finishing therapy, so that I start, working in Freedom from Torture, focusing on how we can center the voice of survivors in order to help us make a decision, which those decisions will lead into whatever the services that we're providing with torture survivor meet their need, and also, how could we be led and also, shaped by, survivors' expertise and insight. So that's how, we always do everything. And for this project is the same methodologies that we're going to be, using in order, to design, the product. In the last two, because every few years we do what we call it, pathway to services. It means, we go back to torture survivors and ask them, how could we shape the services within Freedom from Torture in order to meet your need? And in the last two surveys that we ran, there's one question that keep coming. People need support in between, therapies when flashback, come up, when, people have nightmare, when human support is not there, what other support that, they can, they can get. And that's something that, they keep constantly, asking us, to do. And then solution, for us is the GenAI, so they can provide therapies and also client PTSD strategy for grounding. And then and through that, I think, we have, three questions that we're going to be, looking into through the research. The question one, do survivor think is useful? The question number two, does it work? And the question number three, it is safe and secure. So I'm going to quickly share with you, part of the question number one. We had a focus group just last week? Yeah, just last week with about 10 or 13 survivors, and we went and here some of the responses from the focus group. Survivors viewed the AI assistant as a valuable for a moment of distress between therapy session and when human support is not immediately available. Practical therapy value. Participants thought the tool could help them ground themselves and regain calm and during flashback and nightmare, and to empower empowerment and continued survival. Felt the app could strengthen self-reliance and extend the benefit of therapy. Empower them to manage symptoms independently while still feeling connected. And also they agree the idea is useful if implemented safely, emphasizing privacy protection, cultural and linguistic, tailoring and integration with trusted, therapeutic relationship. So I think that's just this kind of snapshot, from the conversation that. So I'm going to hand it to Jacqui. Jacqui can try to take you through the next question. How does it work?
Yeah. So post-traumatic stress disorder, PTSD, with survivors, one of the key distressing issues for them when they wake up in the middle of the night or when they're alone is flashbacks and nightmares which take them back to the time they were tortured. So they feel it, they see it, experience it, and it could be a full flashback, means the person's completely back there reliving the torture. So you can understand why this is horrific for them and why they might be saying that it could be useful that a therapy assistant, a GenAI therapy assistant, could help them in those moments with strategies that they have co-developed with their therapist. So these sorts of strategies can be things like, so grounding, which is when the conversation is around getting that individual to, if they're in London, look out the window, what reminds them they're in London, name the 5 things you can see, 4 things you can touch, again, reminds them that they're here and now, that the torture is not happening at this moment. It might be they have a shower, it might be they hold ice. 3 things they can hear, again, take them away from the nightmares or flashbacks of the sounds that would be in prison during torture, and instead have the sounds of maybe the road outside, maybe people talking. Smells is a really important one in PTSD, so we might urge them to smell something really strong, smell coffee, smell eucalyptus oil, to again give them a really strong pull back to the present moment. So this is what we try to replicate with a prototype during this pilot phase. So this is an app-based model. It's very tightly around just a script at this point in time and flowcharts with clinician and just around clinicians. We haven't brought clients into this testing yet. And the important thing is as well that there's risk monitoring check-ins. So just as a clinician would, you'd be checking, do you feel at risk of harming yourself or others? Is that the level of distress? And then there would be a different flowchart model to help the person seek immediate support if that was the case. The other aspect is that the model can feed back information, data back into the therapy session with consent of the client. So it would be things like, what were the main triggers? What were the most useful exercises that helped somebody's level of distress come down? So that helps improve the therapeutic process going forward. The next stage, so if we were to get a grant from Wellcome Trust, the next stage would involve being more kind of iterative, a more adaptive model we'd be using, and we'd be asking, clients are asking us to explore things like tone and voice level and make it more personalised is what they're asking us to do as well, which brings me on to the next slide, which is governance structures, risks and mitigations. There's a lot of back and forth at the moment between survivors and the tech team and other mental health experts around how do we manage all of the ethics and security issues around this project, including clients asking for it to be more personalised and not to be treated like children. That's what they've said. They want us to be let them make decisions about what feels safe, but also we're aware of some of the risk issues inherent within GenAI, and we want very much to share the expertise with survivors as we keep going back down around the feedback loop, so we're all learning from each other as we go. Security is massively important to freedom from torture because clients are survivors of state persecution. So it's a whole other level of security we need other than the normal data protection. That's just a quick, I realise time-wise we're running over. So that's a quick view of the kind of long-term visions we've got. You can see the first 3 are around, as we've heard a lot of today already, really improving access and resources to people that are usually excluded. We, for instance, on the pilot project used Tamil as our language that we wanted to switch between, because Tamil is one of our big groups, that's Freedom from Torture, who we currently have trouble getting the right language resources for. And finally, we just very much want to, these might be useful for safe training programs for therapists, and who knows, if it really worked out well, a whole other stage and level further on would be amazing for the people who are displaced, who are suffering from these very distressing flashbacks and nightmares, to have access to something that might help them in the moment wherever they are across the globe. Thank you.
Thank you.
Who is your target user for your technology, and are they the same group of persons who are served by your organization?
So who's you want to start? Yeah, go ahead.
Yeah, it's also.
Yeah, I think because I think freedom from torture right now mainly we're working with torture survivors, and that's including sexual violence, survivors. And for this, so we're gonna start from from this target audience first, because I think we have the inside, and also we have the group of survivors as keen to help us to develop that first.
Yeah, I think that's absolutely right. I think there's we'll start with the client group that we've got that we can work really directly with, but ideally, absolutely, much more widely available.
May I ask a follow-up? Are they based here in the UK? Are they in different countries? Are there any technology limitations, technology literacy, device access? Like thinking from that perspective as well.
Yeah, I think freedom from torture is based in the UK. And the client group that we see are those that come here, the asylum seeker, refugees, and so on. So, for now, yes. And I think the question about literacy and all those, that's the question that we also explore within the focus group that we see. And also, I think we could, the idea is to go through the voice thing, and then looking at, because people suggested, how could we develop something people can use in their mother tongue, so they can communicate. So if somebody cannot write, so they can talk to it directly. So those things that we're exploring with that. Thank you.
Yeah, I think what we do anyway at the charity is people obviously on, you might not realise, people on, for instance, asylum seeking benefits, it's a much lower level of financial support than general benefits in the UK. So they often don't have money for instance, data and mobile phones and things like that. So we do support clients with that anyway, because otherwise how else are they going to manage some day-to-day affairs and start to find support within their own community. So yeah, thank you for that question. I think it's really important to think about those different aspects.
It's very important work you're doing, and I was thinking about something that you didn't address, but maybe it's innovation. Are you collecting the results of the treatment and then feeding it back to the model so it could improve kind of via like a network effect? The more you use it and the more information, the better the model will get.
So was that a question of...
Yes, that was a question.
So we keep evaluating,
Yeah.
So try and compare. So we would have a treatment as usual group, of course, and then we would have this other group where participants have consented to be involved. Right. And I think you'll find that the client and the clinician is going to be could be mutual benefits, right? In terms of the how that then impacts efficiency as well as kind of outcomes related to the therapy. So absolutely.
But does it also fine-tune the model again?
Oh, fine-tune,
yeah,
yes, absolutely.
Yes,
Absolutely.
Okay.
Yeah.
Thank you.
Thank you.
Thank you. Thank you.
Thank you.
Great. So next we have AI-enabled mental health support for conflict-affected populations by Tahir Buhari. Thank you.
By the way, our chatbot that we developed yesterday told me to take a deep breath from my nose and release it through my mouth, before my presentation to reduce my jitters. So, good afternoon, everyone. My name is Tahir Buhari, and I'm here representing our principal investigator, Dr. Abubakar Suleiman Baguda, who unfortunately could not make it, and our Lumana consortium. So maybe before I go into my presentation, I just want to tell you a little story of what happened to us last year. As part of our grant development and proposal activities, for this particular funding call, I had visited an IDP camp in Borno State. And there, I was interested in talking to health workers, in terms of their experience, handling and dealing with mental health issues in these very fragile and, conflict-affected sort of environment. And one of the healthcare workers there, decided to tell me a story of something that happened to her that morning. She had met a young mother. That mother was called Amina. Amina had fled violence from the northeastern part of Borno State with her 3 children. And she was seeking refuge in the IDP camp, to get support. And since she arrived, she was finding it difficult to sleep. She was not eating. She was very anxious around people and very nervous. And the IDP camp manager decided to refer her, to this health camps project that was being implemented once a week in the IDP camp. So when she arrived, the health worker tried to screen Amina using, the WHO MHGAP tool. But unfortunately, Amina could only speak Hausa, and she could only speak her mother tongue of Kanuri, while the healthcare worker could only speak English and her own mother tongue, which was Yoruba. So unfortunately, the support that Amina was looking for, had to be aborted, and she had to be referred to a higher level tertiary facility for her to get support, which was about 120 kilometers from this IDP camp. So this is really the story of what our consortium is trying to address and trying to fix. So I'll try to tell you about what we have done in order for us to do this. So we are trying to address this issue through Lumana. And Lumana is essentially an artificial intelligence enabled mental health support model that is specifically designed by and for fragile and conflict-affected communities, specifically in northern Nigeria. I think my brother had done such a fantastic job this morning, to sort of paint the picture of the mental health crisis in Nigeria. Over 220 million people and fewer than 300 psychiatrists, right? So you can imagine the ratio. I think it's about 1 to 730,000 people. I think if you're comparing it to the UK, I was trying to look at the numbers yesterday, it's something more around 1 to less than 10,000 people. But it's even worse if you're looking at conflict and fragile settings, right? Several studies have shown more than 60% of these displaced populations are impacted by some mental health disorder. And in fact, just last week as well, I was looking at the numbers specifically for youth. And one of the local studies showed that more than half of the youth in these settings actually are experiencing some form of mental health disorders. So we do agree, by and large, with everybody that we do need scalable approaches. But for us, what was more important, is for us to ground these approaches in the local language, the local values, the local stories, and the local realities of the communities that we serve. So we have, our vision is essentially very simple but bold. We want to expand access to mental health services that are culturally grounded in the realities of our communities. Broadly, we have 2 programmatic aims. The first one is on the model capability itself. So we're looking to improve all of the work that has been done, to improve, to fine-tune existing open source models that can process Hausa speech and then generate trauma-informed and culturally sensitive content generation, either be it through psychoeducation or some cultural and behavioral therapy, similar to the advice that I got yesterday, to take my deep breaths whenever I feel a little bit nervous. The second aim is looking at this human and artificial intelligence collaboration. So it was very important for us as well, to make it clear that we don't think we can replace humans and clinicians with AI. As powerful as it is, we are looking at extending the reach, expanding and augmenting and strengthening the existing clinicians that we have to be able to reach more people, within our ecosystem. So how did we get here? I think some of the teams have made a lot more progress than our team, because last month, our PI essentially asked us to go back to the drawing board, where we conducted a lived experience and co-design workshop using Delphi methodology. We tried to take all of the lessons that we've learned from the Neuromatch and MEXA workshop, especially the lived experience workshop. So shout out Joanna. So we took a lot of those lessons and implemented our own lived experience and co-design workshop in Sokoto State, close to one of the biggest IDP camps in Nigeria. So during that workshop, we brought together more than 40 participants, both clinicians, government, health workers, and also most importantly, we implemented in Sokoto close to lived experience participants and individuals who have experience of displacement and experience of what it means to be removed from your community or through violence. So we basically had agreement across some key areas. So our Delphi methodology is essentially a consensus building methodology where you bring out ideas and then you rate what features you think are key to solving these problems in these particular environments. So we ask some key questions, and the basic idea of the question that we ask is, what does it take for you to build an artificial intelligence technology that is specifically meant to support mental health conditions in these very fragile settings? And some key components came out. The first one was that it needed to speak to us in our mother tongue, right? Number two, we agreed it has to be offline, because we believe that connectivity in these kind of environments is a luxury that many, many do not have. So it's very important that if this tool is going to work, that it is offline capable. So what does Lumana actually look like? By the end of our workshop, we were able to name the solution and also understand what it looks like. We decided to build a dual interface MVP. One is that there's a clinician and community-facing part of it, right? So for the community and the individual side, we're looking at a voice chatbot that you can speak to in Hausa that is also capable to screen you offline using PCL5. So we have prioritized which tool we are going to look. In terms of that feasibility as well, we were not able to look at all of the different tools. Then for the clinician-facing side, we are taking more of a clinical decision support system perspective, where we are not looking to replace, as I mentioned earlier, what clinicians are doing, but to strengthen and sort of to use AI to act as a force multiplier, for what our clinicians are able to do and address. So in terms of the organizations that we have leading this, I'm based out of eHealth Africa. So we are providing the programmatic management project delivery for our project. Then we have Kano Independent Research Center Trust, which is a Pfizer setup facility donated to Kano State. We also have Blue Room Care, which is an indigenous telehealth platform that has actually provided mental health coverage for over 2 million people already, and has provided remote consultations for over 20,000 people. Then in terms of the clinical side of things, we decided to take both a for-profit and a public sector approach. We have EHA Clinics, which is a for-profit private sector hospital, and we also have Federal Neuropsychiatric Hospital, Kware, which is a government hospital in Sokoto State. So these are the 4 organizations that are leading our work. Because I only have a few minutes, I'm just going to go through, the key takeaway for us. So for our team, we tried to re-envision that experience that I had in that IDP camp. If Amina, arrived at that camp, and then a health worker, maybe had a smartphone or a tablet that was running Lumana, a tool that can screen her in her own language, and provide some level of support and connect her to the help that she needed. That is what we are trying to build. But we also agree that AI and technology, no matter how powerful, cannot close this gap alone. We need partnerships, we need humility, we need to listen to the communities that we serve, and we need to make sure that, as they said in that lived experience workshop, we are building with them and not for them. Thank you.
On your question of offline, how important is offline versus like asynchronous spotty WhatsApp?
Yes. It's so important. We had over 90% of consensus, at the Delphi workshop. It has to be offline. Because we believe there's not only the issue of the device itself, access to the device, but there's also issue of infrastructure, and also issue of even paying for mobile data. So for me, one of the first projects that I have ever been involved in actually distributed 1,400 smartphones to healthcare workers. And unfortunately, 5 years down the line, none of those devices exist. So we feel like there are systematic issues that we need to address in terms of providing devices for projects. Bringing your own device policy, we think works better in terms of the lessons that we have seen. It's not sustainable for you to buy smartphones and deploy them. Trust me, 3 years on, you're going to look for those devices and they're going to be gone. So we think you should take a bring your own device policy for these type of projects. But if health workers are using it for clinical decision support, we think that it might be fair to provide some form of compensation for using their devices to deliver work, say, on behalf of the government or on behalf of the work that they do.
Just wondering, from your explanation earlier on, with the offline mode, how do you achieve the dual interface MVP between the community and the clinician?
Mm-hmm. So we have already built the first prototype of our chatbot. And as I mentioned to you earlier, some of the team are a little bit ahead of us. In the next couple of weeks, we're actually going to be doing our testing and validation work. So we've already built a prototype of the model. It's now for us to go into that testing and validation aspect of it. But again, I said this is a non-negotiable for us. After we came out of that workshop, it was very, very clear what the lived experience participants said. We had explored WhatsApp, yes, but they felt like I have to pay for mobile data. I have to have a device that is working for me to be able to do that. What we propose is that there are already some safe spaces that are being implemented across IDP camps. So we see the health workers that are running the health camps, for example, the health worker that I met last year. We see those type of staff as being a little bit more resourced to use tools like Lumana.
Hey, hi. So with offline, you mean without internet, right?
Yes.
So you must be deploying your models on the edge devices?
Yes.
Then it should be some smaller models, right? So how you take care about the performance of those smaller models compared to the bigger models?
Mm-hmm. So I'm sorry, our technical person is not here, so I am not able to answer that question effectively. But what we know is that, yes, the model has to perform on your device. It is important for us to be able to function independently, but we want to have some form of synchronization that happens maybe when network is available or when the individuals.
Yeah, well, that was my second question. You said somewhere about real-time alerts in the clinical part, right? So how do you sync your data and real-time?
Yes,
exactly?
okay, that's actually a very important question, because what we also agreed was, for example, for suicide ideation and homicide, situations, that is something that is very, very serious. So we think that is something that needs a real-time alert for a human being to actually respond. So we've looked at potentially addressing that through SMS or through some sort of an analog signal, that will be sent so that, a human immediately within, I think the goal that we had was within 6 hours of a human intervention when we have suicide ideation and, homicide risk. Thank you.
Next up, we have shamiriAI, Scalable Culturally Informed AI for Fidelity Feedback and Adaptive Training in Youth with Rahim, Daya and Shadrack, Lilan.
Great. Good afternoon, everyone. My name is Rahim. I'm the head of strategy at shamiriAI. This is my colleague Shadrack, the head of tech and the brains behind the operation. So I'll talk to the first couple slides and then hand over to Shadrack. So our project is looking at enhancing mental health supervision with generative AI. But a little bit about us first. We work at an organization called shamiriAI, which is a Swahili word which means thrive. And we're trying to kind of transform mental health so that young people are able to thrive through accessible and affordable mental health. And a little bit about the context in Kenya. 1 in 2 adolescents reports elevated symptoms of depression or anxiety. And as you've seen in other LMICs, there's a massive workforce shortage. And so for us, we see lay provider interventions as the way to address that. They're cost effective, built to scale, and are also evidence-based. And so we train 18 to 22-year-olds to deliver group-based therapy in high schools in Kenya. So the picture there is of a provider delivering a low-touch intervention. And it's a tiered caregiving model. So between 10 to 15 of these lay providers are overseen by a clinical supervisor who has an undergraduate degree in a mental health related field, so psychology or counseling. And in 2024, over 500,000 young people received a lay provider intervention. But as we scale, and our ambition is to be working with millions of young people a year, there are challenges with being able to supervise tens and hundreds of thousands of these group sessions. And these traditional supervision approaches that are in person start to break because supervisors can't directly observe all therapy sessions. We do record a sample of these sessions that are then transcribed and rated for fidelity. But once you're in the tens or hundreds of thousands of these sessions, the time it takes for humans to rate and feedback on these sessions is weeks or months long, and the feedback comes too late for us to be able to give effective feedback to providers before their next session. So Shadrack is going to talk about how we're trying to fix that.
Yeah, so welcome shamiriAI. So the problem that we're trying to address is the clinical supervisors and how they're able to provide feedback to the lay providers. So as Rahim mentioned, this will take long. So if you have like 10,000 hours of audio, there's only a few, supervisors at hand, so the feedback comes too late. So what we do, we take the session recording, of course, during that group session, like all the students have given written consent. That's really, really important. And once we take the session recording, we pass it through a pipeline. So what we do, we get a transcript and also some prosodic features. Now for the transcript, one of our first speed bumps was the code switching aspect. So in Kenya, people speak English, Swahili, Sheng, and of course during a group therapy sessions, you want to be able to allow for that, for more fluid interactions. So at first when you tried with the gold standard for translation at that point in time, which was Whisper, you had some really interesting outputs. So we had to spend some time fine-tuning Whisper to produce a good enough transcript. And also for that transcript, it was important for us that it's also not translated, because as other people have mentioned here, translation will lose, as people have mentioned here, translation will cause loss of cultural nuances, so that was really important. And then with the transcript, you also want to get a diarized transcript. So by diarized, I mean we need to know when did speaker A, B, C, D talk, so that even though you have a group session and it was just a monologue, then was it really effective? No. So after that, we then pipe this through some other things to remove PIIs, personal identifiable information, and also to do some augmentation, because sometimes during moments of silence, this AI tend to hallucinate. Someone spoke, so we had to watch out for that. After that, we then pipe all of this to one of these foundation models. For us, it was Gemini, which performed really well, simply because it was able to understand those cultural contexts. I guess because of all the data that Google has with different languages, it did really well for us. If we sent it through Claude or ChatGPT, I don't want to talk about the results, it was not great. So after that, we then we send that feedback back to the supervisors. And this feedback, actually, the point where we do the enhancement compared to how it was done manually. So previously, people will just release a feedback on a scale of 1 to 7 on like 6 different dimensions, but it's just numbers. You never gave a justification. Why do you think this person deserved this score at that point in time? So for us now, we're able to provide that and also include exact timestamps in the audio where something did not, went well or didn't go well, or even flags for content which was not appropriate or should be actually escalated to, up the chain. And then the thing that we want to do in the future is develop this feedback tool to also be a training tool for the lay providers. So if we get good at being able to, take in that audio and then also give you the necessary feedback, you don't have to go in to see a supervisor to be able to help you. You can also role play for yourself to some extent, right? And also, make you be a better provider. So, yeah. We're not trying to replace the human caregiving aspect. We just want to augment it and to be able to do that at scale. So these are some of the interesting challenges with, having LLMs, produce output. At first, we gave the LLM the training protocol we used to train the lay providers. So it used to now just check word for word, did the person say every single thing here. So if you're saying, like, for example, in your open, make sure it's a safe space. The only time I'll breach protocol is if you say that you're going to burn down the school. So it will say now, you didn't say burn down the school during the group session, so that's a bad person. So we had to iterate on that. Other thing was also like things like anecdotes. So maybe like you give an example like, something happened with drug abuse, etc., and you meant it as an anecdote. Right? We'll also say like someone mentioned drug abuse, and there's no, so you tell the supervisor that lay provider forgot to address this issue. So you can ask that during your one-on-one sessions, but that's not the case. So we'd get this really interesting bits of feedback. And then at this point is also, we got to a point where we got like really good, system prompts and be able to have that to a place, which is great. So this is how the PLE part comes in. So what makes a good group session? That's important to define in the rubric. The other thing is also how do you tailor the report? So at first, again, it was just quantitative. Now let's add justifications. Now let's also talk about, here are the strengths of what you did during the group session. Here are some weaknesses. Here are some flags. Now for the flags, the supervisors then told like, this came up in the session. When you're doing your one-on-one check-in, we could ask if that case got escalated or how did you handle this? And we also had, of course, lots of focus groups with the supervisors. That's why at first they bashed us. I come from the tech background. I'm not that personal sometimes. And then like, you cannot deliver feedback like this. This is so harsh. You'll actually make them worse. So here the results. So 314 students and 47 fellows, that's our lay providers, was subjected to this. And then the control group was 17 fellows and 97 students. So across the board, I guess generally group therapy sessions, you will see improvements in anxiety and depression and well-being. However, we will saw that for depression and well-being, someone supervised largely with AI feedback, and someone who didn't have any of that, same performance. For anxiety, however, we found that if AI was not in the loop, your students did particularly better on that. So now these are some research questions because you're being recorded, are you feeling more jittery? Are you not able to maybe handle things about anxiety as much? So these are open research questions, but thank you so much. The questions are welcome at welcome.
Great presentation, exciting work. I'm very curious, your last slide about the difference between depression and anxiety. Do you have any insight on the type of feedback you gave from the supervision? What might have caused kind of this kind of improved performance with anxiety reduction?
No, so actually the analysis here is that if you were, if your supervisor had AI feedback, the anxiety scores for those students didn't drop as much as.
Oh, so it's the opposite. Okay.
Yeah.
Yeah.
Any thoughts on that?
so there's some. It's less of a tech question, more of a research question. So, did the students in the groups that didn't receive the AI feedback, did they have a higher baseline than those that were receiving the AI feedback? This is obviously a pretty small sample size as well. So there are lots of confounders and possible reasons why, and our kind of research team is investigating that on a deeper level.
Yeah, so we just don't want to just build AI tools, but just for the fun of it. Like, it has to be evidence-based. And so all that stuff, we also have to use the necessary measures to see if there are any improvements or subtractions or, yeah.
About acceptability. Oh, sorry, thank you. I'm just wondering about acceptability of AI for the fellows and students, how they felt about it, and if that could have an influence in terms of anxiety.
Yeah, so I'll speak about that. So there's the focus group bit, and also here at version 1, version 2. So actually with version 1, you send it out, like, let's see how it is. And there was so much resistance here. As you can say, as I gave the examples, like, you're just penalizing me harshly. But now with all those, further iterations, and they're in the loop, they're there. Like, even as I'm crafting the system prompt is also like, hey, like, look at how this is happening. So that's how now you get it to a point where, like, it's much, much better. I wish I'd actually included screenshots of how the feedback looks like, but I think some of you have seen it during some of the calls. Happy to show people afterwards.
Yeah, I'll just add to that. That also supervisors they're kind of translating from the AI feedback to the fellows, to the providers. And one thing that we think is good is that they're kind of basing their supervision sessions, weekly supervision sessions that they already had on something, rather than it being really general. Because before, obviously, they have no idea what's actually happening in each session. They're just kind of roaming around, not knowing. And so now that they have actual, tangible stuff to base their supervision sessions on, we've seen that there's positive feedback in that respect.
Very interesting.
I know I'm having to be brutal on the time, so if you do have more questions, just find presenters during the breaks. So next we have PhysioPrompt, using GenAI to personalize VR exposure therapy by Adam Hutchinson.
Hi everybody. I'm just coming off the back of a 30-hour flight, so I apologise for looking tired, but I did realise that the only other time you've seen me is at 2 a.m. on those webinars, so I do look not tired some of the time. Anyway, my name's Adam Hutchinson. I'm the founder of a startup in Christchurch called Overcome, and together with a couple of universities in New Zealand, we are involved in a very exciting project called PhysioPrompt, which is delivering personalised, scalable, virtual reality exposure therapy for anxiety disorders through generative AI and physiological monitoring. And I will explain what that is coming forward. But just thanks to Wellcome Trust for putting this on, because this is amazing and a super exciting time for us. So just want to say thank you very much for that. I'll give you a bit of background as to what we've been doing for the last 4 years with Overcome. We're about to hit a very exciting phase around generative AI, but I want to give you a bit of a backstory first as to the problem that we've been focusing on. Anxiety disorders affect 301 million people around the world. What we know is that 72% of people that have an anxiety disorder that need exposure therapy cannot access it. And so that's the problem that we've been chasing. They can't access it because of cost, location, stigma, and wait lists. Now, exposure therapy is the gradual and safe exposure to what it is that you're avoiding. It's the gold standard treatment for anxiety disorders, but also used in PTSD, eating disorders, and much more. It's a really important therapeutic tool, cannot be accessed by a lot of people. Now, the downstream consequences of not getting treatment are pretty severe. What we do know is that 46% of people that are diagnosed with social anxiety will go on to develop depression. The costs around depression are significant. Therefore, what we've been focusing on is making an early intervention tool accessible to whoever needs it to stop these costs that exist today. These are huge costs that exist today, and that is what we are solving. Just by way of background, so I had social anxiety when I was a teenager. I quit school very early, and I went to go and work on a farm just to avoid people. It had a pretty big impact on my life. I managed to overcome it through exposure therapy. Long story short, was working in a butcher shop, decided that wasn't my pathway, went to university, and after university got into tech, created a startup called Campermate, sold that to Tourism Holdings, the world's largest RV rental company. And in 2020, I was energized and I was hungry, and I was ready to tackle my next challenge, which was this, a problem that was very close to me and close to my heart. Making exposure therapy easy, scalable, accessible to anyone that needed it, and that's what I've been chasing. Now, in February 2021, I put together a team, many developers from my previous startup, and what we released was Overcome, a smartphone app that we could deliver virtual reality exposure therapy simply using a Google Cardboard style headset. So if we think about what the reasons were why people couldn't access treatment, a lot of it was around cost. Therefore, I wasn't going to put an Oculus Quest, Meta Quest in front of them in order to access this. It was very much around just using whatever technology that they had in their pocket already, and that really shaped the solution. So having a very clear understanding of what the problem was and what the causes of it were, that is where you start, and that is how you shape the solution. And so that's been there right from day one. Teamed up with clinicians and released Overcome, started our first clinical trial in June 2021, and I'll talk through what that looks like. But just want to focus that it is smartphone delivered. It is not going after the Meta Quest, although that is a component that I'll talk about soon. Low cost, accessible. We've delivered 150,000 sessions through Overcome, and what we've learned is that over 50% of them happen outside office hours. This is outside when a clinician is available. So what we know is that we've really focused on the accessibility piece, and what we've been able to prove throughout this, through 2 randomised controlled trials done by the University of Otago, as well as a number of pilots that we've had with NHS insurers, is that we've seen a 75% reduction in phobias after 6 weeks of treatment. That was a randomised controlled trial. 50% reduction after 18 weeks in social anxiety. We've also seen a 60% shorter treatment duration. That was for the rehabilitation of people that had a serious motor vehicle accident and had developed anxiety. Now, as a result of being able to get an Overcome headset and the program for them, they were able to get back to work quicker, which you can imagine from an insurer's perspective is pretty good. So whatever way you look at that problem, the solution is really good. We support over 3,000 phone models. We've shipped to 67 countries. And we've got 1,000 clinicians on our clinician portal platform, which is another product that we've got, not the smartphone app. And I'll talk about the importance in terms of the model training from the clinician portal soon. Just a couple of projects that we've done. We've been helping people with autism to go and experience what their procedure is going to be like in the hospital to reduce the 30% cancellation rate. We've developed a program for Allianz in Australia, which has been delivering an intervention for people to help get them back behind the wheel at 5% in the cost of what it is traditionally. But here's where it starts to get really interesting. What we've learned after delivering 150,000 exposure therapy sessions has been that everyone has very, very unique triggers that are associated with their disorder, and that even though they may not know it themselves, their physiological data is painting a very important picture about what those are. Now, one thing that we have been developing is a model that detects what are the trigger responses that exist within the content. This is a model that we've been working on for some time now. Now, if we match what we've got in our VR content up with someone's physiological data, with the knowledge of what their triggers are, that's a very important position to get to, especially if we're focused on accessibility, because it means that in order for us to find out what someone's triggers are, we have not had to do that through expensive hardware. For the most part, it's been done through very low-cost hardware, but if we can get to that position, we can do some pretty important stuff in terms of personalization, and that I'll talk about next. But I just wanted to at this point, state what this means. Of all of our content that we deliver, we know in very granular detail what triggers exist. Now, for the individual that's coming and experiencing that, we also know what their triggers are. And it's this what presents the opportunity around generative AI, and this is why I'm so excited about this phase that we're in. The ability to personalize exposure therapy to achieve great outcomes at scale is only possible now with, for example, the VO3 model. 6 months ago, this was not possible, but it is now. And if we can do this, we can get even better results than what we're seeing, to the extent of 20 to 40% greater outcomes. And this is why I'm so excited about this phase that we're in. And this is, sorry, it's taken a long bit to get to this point, but this is our project. By being able to deliver personalized, scalable VR exposure therapy through generative AI. What this means in practice is that someone downloads the Overcome app, they get sent one of the headsets, which we've shipped to 67 countries, we know how to do it. Now, the content and the program is personalized just for them. It's personalized in a couple of different ways. Number one, the generative AI content, but number two, in terms of what are the next sort of environments that they are going through. That model is being trained off our clinician portal, which has 1,000 clinicians on it today. And by the way, we sponsor that to any researchers as well. So if you're part of a university, you're interested in exploring virtual reality, we sponsor that to any university. We have a number of universities such as Stanford that are using it today. So just wanted to put that out there. So the content is personalised, and the more data that we get from that individual, we can personalise it further. So really go into quite granular detail. This is an example of some of the content here. This is for emetophobia, so a fear of sickness. It's just a bit of a snapshot. This is what we're exploring. I'll try and rush through this next bit because I'm sort of just getting into the detail now. These are all AI generated as people. It's pretty exciting at this point now. You can almost not tell it apart from our video content, of which we've been able to prove that we can get the results that we have. So the research question that is core to our project is, can generative AI create the same SUDS ratings, and can we achieve the same outcomes that we've been getting in our previous clinical trials? And if the answer to that is yes, we're going to see 20 to 40% greater outcomes. So there's four main areas that we've been focusing on as part of this accelerator. Does content get the same anxiety ratings? And for that reason, we've had a clinic with the University of Canterbury where we've had people come through. We serve up GenAI content, we serve up our filmed content. Do we get similar responses? And the early stages of that are very, very promising. Of those 1,000 clinicians that we also have using our platform, we are also serving GenAI content out there, and we are recording the SUDS as well. With our direct-to-consumer product, we also have content going out there as well. So we have a number of sources of data to validate whether or not we can. Now, they're all using this clinician portal product, which is a really big repository of content, over 1,000 different environments, mostly filmed, now some GenAI content, and from that we're capturing data. Can we capture EOG and PPG data to detect physiological data from someone on our headset? As part of the accelerator, we've also been tracking whether or not we can do that. And so this is part of what we've been working on in the accelerator as well. Also very, very promising what we're seeing there. Can clinicians from our clinician portal provide us with data that we can build a safety framework or guardrails around generative AI? We have a feature that is going into our portal probably tomorrow. This is where they can request content. We serve up a preview. We get feedback from that preview. That data then shapes the guardrails. We've got 1,000 clinicians on the platform. We have a huge opportunity for scale, huge opportunity for volume of data. And I think before we submit in December, we're going to see some really interesting data. Lastly, we've got 40,000 people that come to the website and go through a survey around their condition, and it is one source of our lived experience data. And so we've gone out to them to understand, how do they feel about generative AI? And these are just some of the answers that have come through. Basically, the snapshot is, it's early days at the moment. I think there's a lot of education that's needed, and it's going to be a journey. But as we can see from some of these opinions here, it's a little bit mixed. It's a little bit all over the place. But in reality, I think people see this as a huge opportunity, as do we. This is the team. We are all very, very passionate about this. It's an exciting time in the journey of Overcome and this project. And this is the big one. By using generative AI, now that we've solved the access piece, we're really focusing on further reducing that treatment gap that exists, that has been there since day one, bringing that down so people can access it and get better results through personalization of content. Some references, and thank you. So, yeah. Hopefully there's some time for some questions. I'm not sure if I went over.
Got time for one question.
Sorry. But come up later tonight. I love talking about this stuff. So, yep.
Hi, Adam. Thank you very much. Daniel from TU Munich. This is great. Love your product and the approach, and say hi to Mark and Rob if you meet them.
Yeah, cool.
I have just a question to learn from my side. So you said 1,000 clinicians are testing this. So how do you get ethical approval for this within this time for 1,000 clinicians? I'm stunned, but positively surprised.
Yeah. So I think we only onboard clinical psychologists to the platform, and that gives us some wiggle room in terms of how we can test some of this. I guess if I answer this from a legal perspective first, if you don't mind, all of those clinicians have signed up to the portal and they have agreed to the terms in the sense of we will provide content. Now that content may be filmed, it may be computer generated, it could be generative AI content. So from a legal perspective, it is something that they know about. Now the research that we're doing on that, I guess it's fairly low risk because we're presenting them with the options and they're aware of it. They can choose whether or not they want to use the generative AI content or the filmed content. Now, because I had to rush through that, there was another project and it was the photo of someone with the headset on. Now, we've had ethics approval for a project where we were using a MetaQuest Pro to detect eye tracking. Okay, so we were doing a lot of granular research into where people look once they're in the VR, and it forms up our picture of the physiological data. Now, we had ethics approval for that already, and thankfully we hadn't exhausted the number of people that had gone through that, and therefore there was a window for us to continue that research on with the University of Canterbury, and because of that we were able to, to bring people through into the clinic under that same project. And therefore we were able to utilise those results. We are still utilising that. So it's a roundabout way of saying, because we already had an existing ethics approved project which we didn't have to adapt or change in any way, it meant that we could still use data from that to help us de-risk this and understand if we serve up generative AI content, can it create the same level of SUDS and therefore get the same results that we've been seeing in our clinical trials to date, which, like I say, 75% reduction in the severity across 5 phobias after 6 weeks. It was a large effect size, 120 people, randomised controlled peer-reviewed trial. Really, really strong result for us, and backed up with the social anxiety clinical trial as well. So hopefully that answers your question. Like I say, love talking about this stuff, so please come up to me later today if I'm not asleep at the table. But but thank you very much.
Thank you very much. So last for this session is AI advocates safeguarding dignity and equity in inpatient psychiatry with Michelle, Patriquin, and Nicola Polizzotto.
Hi, everyone. We'll try to make this painless and quick, and so we can get to the break. I'm Michelle Patriquin, and we're gonna talk to you today about a little bit different of a use case for inpatient psychiatry. We talked at the beginning about how generative AI doesn't really fit mental health, and I'll tell you, not only does it not really fit mental health, it definitely doesn't fit inpatient psychiatry. And one of our goals at UT Health Houston is really thinking about how technology can improve outcomes, particularly in inpatient. We have multiple publications in this and technology implementation, development models specific for inpatient psychiatry. If anyone's ever interested, it's such an important opportunity to really leverage and use technology to improve outcomes. So we're going to talk to you a bit about that today. I'm a clinical psychologist at UT Health Houston, and I'm joined by my colleague here. I'll introduce himself.
Hi, it's Nicola Polizzotto. I'm the physician lead for the project. I'm the associate medical director of the hospital, director of the psychosis program. Our project was inspired by the response or the feedback about admission of one of the 14,000 patients that we admit every year, that's not that bad, every year in our hospital. And this is a large safety net, is when everything fails in that moment, we are there to help. So it's very critical what we do. And unfortunately, in those situations, some of the patients for the kind of pathology that we, for the acuity of the moment, for the pathology, but also for the process, they struggle to remember what happened, they don't feel informed, they feel unsupported in many ways, and they feel like alone in that moment. And our mission was inspired by the core principle that no one should really, in that moment, admit to inpatient alone.
Yeah, so our goal is that if someone consents and they would like, they can have an advocate or AI advocate join their inpatient admission, really to reduce what Nicola is talking about, the anxiety, sometimes even re-traumatization, some rights-based issues, trauma-informed care issues, evidence-based care issues, and really to hopefully provide a supportive tool that really improves their admission process, the psychological safety they feel during that admission process, and their understanding of it. People can be very disoriented. Our patients have psychosis, anxiety, depression, and or something else, right? So we have a lot of co-occurring disorders. And so our goal, really, like Nicola said, is that they don't have to admit alone. We created this tool, and we'll describe it in more kind of detail from a workflow standpoint in a moment, to have two outputs. A patient-facing output that provides a layperson summary of what happened during the admission process. These are your rights. This is what happened, this is what you said, but then also provides them sort of a warm handoff onto the unit. You gave us this information about, you are very concerned about housing after you discharge. That's good information to share with your social worker. Or you said you're very socially anxious, you're really worried in social situations. You're going to walk onto a milieu or a unit with 24 people. These are some ideas of things that might help you as soon as you get on the unit. To really help them and be therapeutic. But we want to highlight at first how important lived experience has been to our project, even thus far.
Yeah, so we met every week with our lived experience board, and they helped in many ways. One immediate ways is how we're gonna present the advocate for the patients, and we are going for this third witness part, conveying a sense of safeguard protection. The immediate response was not liking it. It was an immediate sense of feeling that in a very difficult moment where they're already frightened in many ways, this had actually a layer of fear if we were going for this kind of look, and they were looking for something that was inspiring, more warm, welcoming, and trust.
So we actually totally changed AI advocate immediately, because we were like, whoa, that's exactly what we don't want to do. We want to inspire trust, and that's so important. We have a whole paper dedicated to technology implementation and development for inpatient, and the only thing we talk about is the role of trust. Trust providers, technology trust, and if even the way it looks is not trustworthy or does not inspire trust, no one's going to use it. The patient's not going to use it, and the clinician's not going to use it. And so actually one of our lived experience board members does digital design for NBC Nightly News in the United States. We are extremely lucky. She developed a mood board for us, and we were like, go, we're going with this one. So it's just really tremendous.
Yeah, so
Yeah.
looks matters, but looks also aligned to the overall like mission. So we're going to bring lights for this very dark moment, but also bring light to a very, I would say, what is a black box where things enter, you don't know what actually happens. And unfortunately, inpatient psychiatry is taxed by being very difficult to access to like measurement-based care. And I advocate is not only like support for like in the sense of like providing like a feedback for the patient or providing like track of what happened, but it's also a way to introduce measurement-based care and generate like data to improve the process.
So we're going to quickly walk through our workflow, and every step of this inspired by lived experience. And really one of the first steps, right, is consent. A patient has to consent to have AI advocate on and in the room.
And consent, another thing that we learned very quickly from our lived experience board is that it has to be very tangible, how they consent or not consent. There should be a track of the advocate being activated, not activating, so it goes through an object that can physically take outside the room. I'm very directly aware of how a patient with psychosis would like react to introduction of a technology, and the sense of control on the consent is also goes through the control of the object, being able to stop it, knowing what is recording, and possibly remove it from the room if it's necessary.
Mm-hmm. So we use ambient listening, but that's ambient listening with active consent, like we just mentioned. We generate a transcript and use natural language processing to process that. Right now, we're using ChatGPT for the AI interpretation and to align with trauma-informed care frameworks, evidence-based care frameworks, and then move that to a database. And then we have report generation, one for the patient, one for the provider to inform care, which we'll talk about in a second. One of the important layers and one of the really significant strengths of using LLMs or generative AI is that we can use all of this different data, ethics, federal laws, state laws, our hospital policies and procedures, looking for alignment with that. But one core thing that we've been talking with Google DeepMind about is that we can now turn the nuanced qualitative experience of inpatient psychiatry and that experiential knowledge that oftentimes is extremely valuable. You can have staff members who worked inpatient psychiatry for 30 years and they can de-escalate a situation, in a couple minutes, whereas somebody that is going to escalate that situation, and they just have tremendous skill that now we can capture with these LLMs and generative AI and turn it into quantitative data, which is just a tremendous asset for inpatient psychiatry.
Yeah, so in our prototype, we also worked on how the providers facing like output, actually first the patients, that's where everything started from actually. The patients facing output looks like actually, again, our lived experience board drafted the first output and the way they would likely to work. And this is very tailored to the presentation output that would guide them through the next step in the inpatient is really lay the ground for the success of the therapeutic alliance also for the rest of the hospitalization. And there is also a feedback for the provider that highlight what went well, what went wrong, to facilitate the learning experience. That it's something that echoes something that we talked before.
So the goal is really to start this learning mental health care system within inpatient psychiatry. AI advocate and admission is just one step in that process. So, I got the 1 minute sign, so we're gonna be really fast. We just really wanted to highlight in their own words how our lived experience board feels about AI advocate. And the first is they provided some quotes around patient support and emotional safety, a key component of trauma-informed care. And that I'll just highlight the middle one. This comes from actually the MEXA matchmaking service connected with us with the individual who helped us generate this idea. And she said, I wish I had AI advocate during my last admission, someone or something to reflect back what it was happening in the room because I couldn't. She struggles with psychosis and has had multiple inpatient admissions.
Another common thread is, was highlighted, I think, in the first bubble here, that the model is not getting better for the sake of the model getting better. It's getting better for the sake of the clinician getting better. It's important because it came, we talked about some like witness or someone outside, but it was actually the patient that brought back in the picture the clinician. So what we are actually advocating here is not the patient itself, but is the therapeutic alliance. So there is, as we say, there is no really replace for the human, but as humans we can do better. We can check for our bias. The interaction can be generated, data can be measured, and can feed again back in the learning cycle.
And that we're just very focused on human-centered AI, and I love this quote, human is not just in the loop, the human remains the leader and the expert with AI advocate. So this is our team. We're a team of psychiatrists, administrators, a chief medical officer, psychosis experts, anxiety and depression experts, inpatient admission experts, AI and ethics experts, all from UT Health Houston, our lived experience board, Google DeepMind, and our hospital down here. We are the largest academic inpatient psychiatric hospital in the United States. We have 538 beds and see about 14,000 admissions a year.
Please reach out is the way to do it. If you have no time to ask very difficult questions in this moment, you can do it afterwards. So if you want to collaborate or advocate for the AI advocate, please reach out. Thank you.
Trust is really hard to build and it can go out the window. How did you build consensus among all your clinical staff to embrace this process and not derail it?
So the question is about like the staff, like the clinicians.
Your whole clinical team, because if it only takes one individual not to buy into it or even passively not buy into it, to be perhaps more disruptive than that one individual should be. I just wonder, because it's a multidisciplinary stakeholder thing. How did you build that from the beginning?
I think there is a commitment to continuous improvement at our hospital. And how do we do that, right? And there's so many different ways we can do that. And that's how I think we've advocated for AI advocate is that it's going to help us improve and give us data to improve the care of our patients and us as individuals, as providers. Both Nicola and I'm a psychologist, he's a psychiatrist. We're both clinicians also on the ground, on the units all the time.
Yeah, so aside of a lived experience like a board, we have a clinicians like a board that actually helps to implement like the nuances of the process. So working like jointly through also hospital administrations, we're trying to like gently enforce by like fostering a culture for care improvement, measurement based possibly.
Thanks for sharing your work. I was curious about where these recordings take place. Is it when they're in the emergency room? Is it when they get on the inpatient ward? Is it just their initial interview, or is it an ongoing thing?
Yeah, so initially it is going to be, like for the prototype in our stage 2 application, it will just be in the admissions area. We have talked about a long-term goal, especially with our lived experience board, of how AI advocate could actually join throughout the length of stay inpatient and join for really kind of intense or just times that they would like the treatment team meetings where they may feel very alone, especially, if you're in a treatment team meeting with psychologists, psychiatry, residents, and then it's you. And so the goal is, initially we have to do one use case and, we already have a lot to kind of figure out technically and, in terms of trust and buy-in, all of that. But yeah, the dream is that it could actually, if somebody wanted, they consented, they could have AI advocate with them throughout their length of stay.
Have you identified patients for whom it's contraindicated or patients for whom it's specifically useful?
So, well, I would say it would be indicated for everyone. And I mean, with the ideal down the line is that is not, I mean, could be possibly something that is not only consent regulated, it would be regulated in other ways like higher order and everything. But this is the ground level where we actually learn what works, what doesn't work, in which way it could work better, and learn from this experience. The bridging with the inpatient world, like this is this first door, and we don't want it to be dark in many ways. The critical aspect also that when things go wrong in an inpatient world, sometimes is like continuity of care that is lacking. Someone is we talked about this being there present in the initial room, but it can lay the ground by this the true feedback, bridging what can work for these patients inside the hospital, and the other provider can access to that. And I think that it's kind of like a universal, would really benefit if you're for any kind of patient.
And I work with, Karen Milligan. I am at Toronto Metropolitan University, clinical psychologist as well. I work with mums with problematic substance use, some of whom will end up in the emergency department at times. And I'm just wondering about who owns the data. So that would be I could see this being so incredibly helpful, but the worry about it being, where does that data go afterwards? If it's recorded, can Child Protective Services get it, for example, things like that, and how you've dealt with that?
Right. It's a big problem, which we're still working through some of the details. But part of our goal is to make, for example, the transcript disappear within 24 hours. And not disappear, delete. And then also making it, and we've talked a lot with our lived experience board. We're so lucky. Another one of our lived experience board members has psychosis, inpatient admissions. She also has bioinformatics background and specializes in AI. And she said, so important that an individual would have complete control over their data. So at any point, right? So when we talked about informed consent at the beginning, we actually are talking about an active informed consent process where we're reaching out, and we're not just saying you've got to reach back out to us if you don't want your data included. We're going to actively reach out on certain cadence to see if they continue want their data within the model. And if not, then they can, we can delete it for them and give basically a receipt of it, or they can actually go in and delete it all themselves, and they can have a copy of it. And we would remove it completely. And so we have in our prototype a patient-facing portal designed where somebody can go in and delete their own data, right? Because there's a lot of paranoia around data, AI use as well, especially dealing with patients with psychosis. And so we're really talking about transparency. Transparency is a huge part of trauma-informed care as well. So how can we be as transparent as possible with also the technology?
We have miraculously kept to time. Thank you guys so much. You now have a break until 3:25, and then we'll be back. I think there's coffee and tea back there. Thank you very much.